My name's Emily Hutchinson. I'm going to be doing a lecture on the neurovascular assessment at the bedside as a part of our stroke education as we move forward toward comprehensive stroke. And we are going to get started here with the initial assessment. The first time that you do your neuro assessment, you should be getting a pretty comprehensive evaluation of your patient. The essential components are going to include things like their mental status, level of consciousness, how are they reacting to you, interacting, movement sensation, cerebellar function, reflexes. The whole point of getting all of these in your initial assessment is so that you've got a baseline for further assessment comparisons, and so that you can determine if and when a neuro change should occur, because one of the most important things to remember when we're assessing neural patients, particularly stroke patients or patients who could be stroke patients, is when did the symptoms change? What is our last known well? Timelines are very critical so that we can provide the best care that we can. So it's very important to be able to say, okay, this was not present when I did my assessment at this time. Now I'm seeing a change. It's very useful to have a good understanding of what the patient's baseline is when you start your shift. Starting obviously with level of consciousness, this can be one of the first signs of a deteriorating neurological condition. This can be complicated, or the assessment of this can be complicated by patients who are on any kind of sedating medications, narcotics, if they're post-procedural coming out of anesthesia. If they've got a history of dementia delirium, that can also impair your ability to assess their level of consciousness. But everyone can be assessed in one way or another. It's just kind of reacting and reflecting of what they've got as their medical situation in the hospital. Sometimes you need to resort to things as sternal rubs, and sometimes you walk into the room, the patient's looking at you and awake and alert, and starting off from a very different place. The terminology with regards to level of consciousness is not really crucial. I'd really rather, you can read through this list. It's kind of interesting to see what the different terms actually mean, but not everyone's going to use these terms the same. Having an understanding and a description of what the patient is doing for you can be equally valuable, if not more so. This way we can, again, refer back to our initial assessment if something should change, but something that you might call obtunded, someone else might call stuporous, and we don't need to bury ourselves in the words of it so much as just describing and understanding what we're seeing. That is certainly more useful if you're speaking with the neurologist, or if you have to call one of us nurse practitioners to tell us what's going on. The description's more useful for us as well, because all of us have a little bit different of an assessment when we're looking at a patient or the way that we observe things. Assessment tools, we've got a variety from the NIH, Glasgow, and Muse, which bedside staff is relatively familiar with. NIH is training that all of you have or will be doing to kind of get comfort with the stroke assessment. GCS is a little bit less specific for neuro and stroke, but is also kind of just the basic assessment of consciousness. And the Muse just calculates early clinical risk of patient deterioration. Our rescue nurses are fantastic at kind of responding to concerns by bedside staff and kind of knowing when to throw in a little extra neurological assessment if they're seeing that we're ticking some of the boxes that would qualify a patient for needing such a thing. Okay, when it comes to mentation, obviously we want to look at their orientation. We want to see how they're understanding us. The term confusion gets thrown a lot around in neurological patients and can be often misused. Sometimes people are reported to be confused when truly they're having an expressive aphasia, or they're not comprehending you, they're having a receptive aphasia. Global would be the presence of both. Patients can have hearing impairment that can make it difficult. They maybe are only understanding what they're hearing, which might not be very much, particularly in an age where we're all covering our faces and mouths with masks and muffling our speech for those who are hard of hearing. It's important to differentiate which is present. This is why we kind of have a manner of approach when we're doing our mentation assessment. If you've got family members at the bedside, it's important to make sure they're not being too helpful when you're asking patients to do things. It's a good practice to say, can you close your eyes? Can you wiggle your toes, without mimicking for them, without very clearly and obviously uncovering their feet, because people can copycat you without actually comprehending you. So are they answering appropriately? Are they substituting incorrect words? Are they saying yes to everything or no to everything? I've found myself in an assessment before realizing that I didn't initially see they were repetitively saying yes, and it just had fit the conversation thus far. Then I realized, okay, I better ask them a no question so I can determine if they're understanding me or not. There's different things that are types of aphasias, like perseverating, where you might ask them their date of birth, and then you ask them, where are we, or something else that is not numerical, and they continue to state their date of birth. That's perseverating. Word salad is using a bunch of real words in an abnormal order so that what you're saying does not actually make sense. Again, I had mentioned a little earlier about following commands. Differentiate confusion and encephalopathy with expressive receptive aphasia. Start with verbal cues on one single side, and then you progress to things that are more complex, like crossing midline. If they're struggling with that and they can't comprehend what you're saying, you can proceed to do mimicry, because useful assessment, you're going to have to know if they can do things with their body even without being able to comprehend you. So it's important to just have your progression if they're not able to participate in the way you prefer. Cranial nerve assessment. This is something that we don't expect bedside staff to get very deep into, but it is important to have familiarity. Pupil assessment is especially important because level of consciousness can be reflected in changes in pupil shape, size, and reactivity. It's okay if you see someone with an abnormality when you're doing your initial assessment to ask them, is that normal for you? Some people have had injuries to eyes or surgeries that may change the way that their pupils react or cause them not to react. It's obviously very important to know if this is something that is not new, then we don't report it as something of concern, because it may have been present their whole life or since a surgery on a cataract or something of that nature. Extraocular movements, is their gaze conjugate? Do they have a preference in their gaze? That would be like eyes deviation toward the stroke. Gaze deviation, they may also have visual neglect. They may have a visual field cut, which can be tough to differentiate because sometimes those patients are also not able to interact as plainly. Facial symmetry at rest and with movement, this can be subtle. Once again, important to know baseline. Is that the way your face always looks? You can say that in the most polite way that you can find. I actually had a patient recently who came to us with speech changes and a facial droop from a nursing home. When I admitted him because he actually had stroke, the following day I spoke with his daughter, who said no, he's had facial droop and dysarthria since he had a craniotomy in 72. Incidentally, obviously he had a stroke anyway. I'm glad we did pictures, but if I had known that all of those things were not new, anytime recently new, it might have helped me to understand him a little bit better and not feel so foolish when I'm speaking with his daughter about his new facial droop, which is not new. Motor exam is going to be variable, what you can obtain based on the level of consciousness of your patient. Always assess and compare bilaterally. Look at your strength in uppers and lowers, distal and proximal. It's important, again, to evaluate for any sort of baseline impairment. If they've got a torn rotator cuff, if they've got lumbar pain that causes them to have difficulty lifting their leg off the bed, make sure that you know what's acute, what's chronic. They could have an old stroke with some residual weakness. Is the weakness new? Is it worse? Is there atrophy in that limb to indicate that this has been there for some time? I get neurological consultations sometimes where the patients can tell me straight up, oh yeah, no, that's been there since I had my stroke in 2016, and I'm consulted as though it's a new weakness. It's important to do those follow-up questions just so that we can know our patients a little bit better. If the patient can answer questions regarding their past medical history, a thorough exam of the chart, family, you can find your resources where you are able. It can be difficult sometimes, especially if they're new to our system. So give it the best that you can. In an unconscious patient, motor response is assessed in response to noxious stimuli, nail bed pressure, pinching of extremities. You want to observe for spontaneous movements before you get to any of the mean stuff. Are they wearing wrist restraints? If you walk into a room and a patient's only got a restraint on their left arm, clearly they're not moving their right. Are they pulling at tubes and lines? Are they squirming around in bed? Sensory and motor overlap quite a lot in the unconscious patients because you need to sometimes assess for a motor response to sensory stimuli like noxious, pinching. It can feel very cruel to be doing these sorts of things, but patients who are unresponsive, it's difficult to determine without the noxious stimuli. Central stimuli can be progressed to if you're not getting anything in the periphery. What's their response? Is more reliable because sometimes the peripheral responses can be reflexive. Like if you scratch the bottom of their foot, you may see a triple flexion response, which is bending of the hip, knee, and ankle joint, and is not actually the patient's deliberate pulling away. That is a reflex, and it's not coming from the brain. It's not volitional. Family can be encouraged by that in some cases, and it's important to differentiate for them that this is not necessarily a sign of a change or improvement in their mental status. I know we don't like to give those kinds of feedback. We like to try and be encouraging, but also it's important to not let them be encouraged by things that are not meaningful. When it comes to sensation assessment, obviously having a cooperative patient that's interactive is much more useful than having somebody who doesn't understand what you're saying, is unable to interact appropriately. You want to compare side to side using light touch. You can certainly progress to pain sensation or sharp versus dull. In patients who have sensory problems, when we do our assessment, we'll usually proceed to things even including vibration sense, proprioception. When you're doing a sensory assessment, you don't necessarily need to get that deep, but just starting distally, moving proximally, and using an organized approach just so you can keep your left and right straight. And sometimes patients aren't going to have a logical presentation of sensory change, but it's important just to document what they're able to give you in your interaction with them. Proprioception, in case you're not recently familiar with this, is just the awareness of limb placement in space. Usually it's like wiggling a big toe with their eyes closed. Am I holding your toe up? Am I holding your toe down? It can be a sign for people who've got some neuropathy changes. If nonverbal but understanding, patients can still participate. Just have them point to the side that's being touched or raise a finger, kind of explain it so that you can work your way through the assessment in spite of that barrier. Reflexes, there's several that we do as a neuro team at bedside. They're not going to be as important because I'm not expecting you all to carry around reflex hammers, but in especially our less responsive or unconscious or intubated patients, we've got corneals, cough, and gag. Plantar reflexes can be kind of interesting, but I don't suspect that anybody's going to call me because someone's now got an up toe. That's not going to be the first sign that we see. So probably not something that I would expect you to be paying close attention to. Once again, if you're working in critical care, it's important to be aware of corneals, gag, and cough reflexes. So change in neurostatus is obviously something that we need to be very tuned into. Timing is essential when it comes to stroke. We need to know the onset of symptoms. We need to know last known well. They don't always represent the same time. If family was present with the patient, maybe they can provide the information. If they came from an outside hospital, maybe we can call staff there, call staff in a nursing home, look at nursing reports, or talk to EMS. Did the patient come from surgery? Sometimes you need to look back to pre-anesthesia symptoms or absence of symptoms. As the treatment windows continue to grow for potential intervention, this is not going to become less important. It's very critical for us to have at least our best estimate of when the patient was asymptomatic versus when their symptoms may have begun. There are several atypical exam findings that can be a little bit difficult when you're assessing a stroke patient. These are things that often get missed when even an ED physician is doing an assessment of a patient who might present with stroke. Posterior circulation stroke symptoms can include things such as dizziness, vision changes, nystagmus. You can have nausea and vomiting with severe headache, third nerve palsy. You can also have some small vessel strokes that will have waxing and waning symptoms. This may be something that is expected with the type of stroke that the patient presents with, but you need to be sure that the physician is aware of this and comfortable. If they are unconcerned of the fluctuation, they will let you know. So if you're noticing a major neurological change, make sure that you're reporting it to the provider. They will tell you if they don't want you to continue to call for such things. Always important to report any major neurological changes. And just some basic reminders, accurate and consistent documentation. Make sure that we are going to notice these subtle changes and see if our patients are having something deteriorating while they're on our clock. Verbal communication is important. Important to know patient history, get into what's new, what's not new. Regardless of how long you're taking with your patient, you want to make sure that you compare it with the previously documented exam, not to copycat what you wrote earlier, but just to see, is it looking the same or am I noticing that there's something different? Things that are changes, things that are new, you want to recognize and report. You want to know your patient very well. If you call the physician, they're going to ask you a lot of questions about what's going on, so it's important to have good documentation to rely on so that you can report everything that you've been observing. I kind of like this slide. It's just kind of informative. I don't expect everyone to be memorizing these things, but it's the different mechanisms of ischemic stroke that you can see, from thrombotic to embolic and hypoperfusion type strokes. The hypoperfusion is going to be more in response to a patient who undergoes cardiac arrest, if they've got low blood pressure, if they maybe were in surgery and had a significant dip in their pressures, and maybe they've got some athero intracranially that's going to lead to inadequate perfusion of the brain. Thrombotic and embolic can come from a variety of sources, and the effect can obviously depend mainly on the vessels that are involved. I guess here I just kind of like visualizing the different blood vessels and areas of the brain that they support. Obviously, this is something that our physicians are always looking to and evaluating for based on patient presentation. They can usually tell you what's going on before we have pictures to confirm it. I've got pictures like this hanging all over my office just because I like to be semi-familiar with that. These are kind of useful tools if you just want to learn a little bit more about different types of symptoms that can come from different types of strokes. So I don't know, I like a good visual aid. I won't describe that too much, but they're available all over on the Google if you have some time. And that would wrap up my neurological assessment lecture. I guess you can always find me in the hospital if you've got questions about things. I'm happy to visit with you. And we hope that this can help everyone get a little more comfortable with their evaluations.